Hello, hope you guys are doing well. Today we're going to talk about spinal cord injury. Hopefully my PowerPoint will go to full screen. Okay, last time it wouldn't do it. I had to re-record. Okay, so what a spinal cord injury is. It's just damage to the nerves traveling through the spinal column. It may have lasting and irreversible effects. Sometimes it can be reversible, oftentimes it is not. The anatomy, just a reminder of the anatomy. Your spinal cord has gray matter and white matter, just like your brain does. The gray matter is in the middle and has a dorsal horn, which is the back portion, and a ventral horn, which is the front portion. The white matter surrounds, and it is white because of the myelin sheath surrounding the axons. There are nerves that go into the spinal cord. Those are the sensory nerves, and they go up, so they ascend, and then the motor nerves come down from the brain and go out, exit the spinal cord to tell our body what to do. There are various tracts in the spinal cord. Some of them ascend, some of them descend, some of them cross, and some of them are on the same side. So I don't care that you know the names of the tracts, but I do want you to understand how the pathways travel. So the sensory fibers always ascend, so they come from the skin, they go up to the brain to relay that signal. Those that are responsible for fine touch, vibration, proprioception, all ascend on the same side. So if they're coming from, see, that's the dorsal, so that's the back. This is the front, so this is the right side of the body. Then they would go straight up the right side as they travel up the spinal cord. There are others that cross to ascend contralaterally. So that's pain, temperature, and pressure. So usually it'll go up a level or so and then cross to the opposite side and continue going up the rest of the way on the opposite side of the spinal cord and then stay on that portion of the brain. So that signal is relayed on the opposite side of the brain. With the motor tracts, they descend, they start in the brain and they go down. There are pathways for voluntary motor control that are contralateral, so they go down and they cross and travel to the opposite side of the body. And there are some that are ipsilateral that go down and feed the same side of the body. So depending on which pathways you're talking about. So some of the pathways go straight up, some cross, some go straight down, and some cross. And that's going to be important when we determine how a spinal cord injury affects a patient and learning the effects of the spinal cord injury. It matters where it has ascended or descended on what will be affected. Some of the causes of spinal cord injury. There are two categories, non-traumatic causes and traumatic causes. Non-traumatic are some of the things we've already learned about, more like neurological disorders. So polio, spina bifida, that's a congenital disorder, multiple sclerosis, Guillain-Barré syndrome, things like that, that affect either the myelination or the development of the neurons in that spinal column, can cause a spinal cord, I'll say injury, but it's really like a disorder that affects a spinal cord. And then traumatic could be a car accident, sports injury, gunshot wound, physical assault, falls. I didn't realize how often, I said this in class the other day, but I didn't realize how often falls contributed. Now, every website I looked at had different numbers on the proportion of spinal cord injuries caused by each category, but all of them, motor vehicle was first, falls was second, and sports was down the line, third or fourth, which is pretty interesting because I thought that would be one of the top causes. So some of the categories, there are flexion injuries, hyperextension injuries, compression injuries, and then flexion rotation injuries. We'll learn later that some of the angular or rotational injuries are actually we talked about it with concussion, more detrimental. Remember, we talked about that with concussion on the last lecture because they separate the brain stem is kind of pulled away from the brain matter, and so it can really be have more negative effects with rotational forces. Okay, so different other types of spinal cord injury. Concussion, so like a pushing on, a bruising of the area. Contusion or compression. Contusion is really a bruise. Compression would cause the same thing. Dislocation is also like a severed spinal cord, so it's kind of broken into two pieces. It's completely cut. Distraction is like pulling away from the area, so it stretches and makes that portion more thin and damaged. And then a laceration, like a cut into a portion, like a stab wound or something that has just a chunk missing. Those are all primary. Wait, did I do? Yes. Those are primary injuries of exactly what occurred versus secondary injuries. So with primary injuries, it's a direct impact, something traumatic caused the injury. Secondary injuries are caused with changes in like the environment surrounding the spinal cord. So vascular changes, either they're not getting enough blood supply, or more commonly, they're getting too much blood because blood vessels are broken in the area. So blood is just pouring into the area. And remember, when blood is pouring into an area, then it becomes, it changes that pressure gradient. So it's already full and it doesn't have a need to pull more blood into the area. And so then the new blood that has nutrients and oxygen is not being delivered to the area because it's already got more blood than it can handle. That also causes increased pressure in that area and pressure on the spinal column. The nutrients and the oxygen don't get delivered there. Then there's a chemical change and toxin buildup. So as toxins are hanging out in the area and not getting transported out of the area because of the damaged blood supply, they begin to build up, and it just creates a bad atmosphere for the cells aren't getting their nutrients, but they're getting more of the bad toxins, and that can lead to cell death. And of course, this then triggers an inflammatory process, which kind of keeps it going. So it's one of those processes where inflammation really is supposed to clean up an area and rebuild an area, but unfortunately, in this case, it sends, a lot of times it's like it sends too much to the area, and the inflammation itself causes more damage, and the rebuilding that occurs is more like scar tissue. So it's not usable matter that can conduct nerve impulses. It's just kind of a filler for the area. There's a video that I have below, yes, that I will put in the PlayPosit so that you can watch. That's really good about explaining exactly what's happening on a cellular level with this secondary spinal cord injury. I think it's very helpful. I would definitely recommend watching that and getting a little bit better understanding of what's going on and what causes continued cell death even after the initial spinal cord injury. Complete versus incomplete. So a complete spinal cord injury, there is no preserved sensation or motor function below the level of lesion. So if the level is down low, let's say L3, that has to be higher because it's affecting the hands. But there is no sensation, no motor control below that level. Versus, an incomplete spinal cord lesion. With an incomplete spinal cord lesion, there is not complete damage. There's some sensory and or motor function below the level of the lesion. And with the incomplete, oftentimes they have more of an opportunity for gaining strength, gaining function back, versus with a complete, it's going to be, you know, 0 out of 5 motor control and 0 sensation. So there's going to be very little room for gains there. All right, signs and symptoms of spinal cord injury. So spinal cord injury, the signs are sudden or progressive onset of muscle weakness, numbness, tingling, pain, and the pain could be in the trunk, it could be in the extremities, and then loss of bowel and bladder function. So if somebody comes into the clinic and they suddenly say, you know, it's weird, I've been peeing on myself, or I've been super constipated and I can't really feel the urge to go, or any sudden change in that, I would recommend they see a neurologist quickly, because it could very well be a spinal cord injury or a Cauda equina syndrome, which we'll talk about later. ASIA scale. This is a scale used to grade spinal cord injury. So ASIA stands for American Spinal Injury Association, and they have a scoring system too. It's supposed to have help clinicians grade spinal cord injuries. The ASIA A is complete spinal cord injury. There's no sensory or motor function in the sacral segment. So where the nerves are exiting from the sacrum is really what we're looking at most importantly, for the most key for these ASIA gradings. For ASIA B, it's called a sensory incomplete. So there is some sensory function below the level, but no motor function. Versus ASIA C, there is some, it's called a motor incomplete. There is some motor function below the level, but most of the muscles below the level have less than a 3 out of 5 muscle grade. So with a motor incomplete, most of the muscles below the level have less than a 3 out of 5 grade on a manual muscle test. Then with the ASIA D, it's called, is it called? I have it as motor incomplete. I'm sorry. I'll verify that in the chat for the play pause it. But there is motor function preserved below the level, with most of the key muscles having a muscle grade of greater than 3. So this is kind of return to function, that the muscles are starting to be strong, but there was an injury at that level. And then at ASIA E, they have normal sensory and motor function, but they still had a spinal cord injury. So they still are on the scale, even though at this point their sensation has returned and their motor function has returned. Okay, key muscles. These are muscles that should be present if there's an injury at that level. Now, at the, we'll look at the way that the nerve roots exit. So, and that can help clarify kind of how they get the level and how they name it and all that stuff. But for each level, you can test, and the key muscles are something that is available at that level that would not be available if they had an injury at the next level up. So like at C5, the patient should have the use of the biceps and the brachialis, so their elbow flexors, and should be able to use elbow flexion to benefit them, versus if it was C4, they would not have any elbow flexion. Okay, so the key muscles are muscles that are available for use, that they have some strength with someone who has an injury at that level, but if they had an injury above that level, they would not. So C6, wrist extensor. So basically that means with C6, they have wrist extension, but with C5, they're not able to do that. It's more floppy. C7, elbow extensors. C8, finger flexors. T1, small finger abductors. And then once we're getting down to the lumbar, we're talking about the legs. So L2, hip flexors. L3, knee extensors. L4, ankle dorsiflexors. L5, long toe extensors. S1, ankle plantar flexors. And then S4 and 5, external anal sphincter. So if you have a C5 injury, you will have elbow flexion available, but everything from that level below will not be available. You won't have any of the wrist extension or elbow extension, nothing in the legs if it's a complete injury. So getting an understanding, I do want you to know these and learn these and understand these. One of the ways that we assess a patient, we test motor function and sensation at each of the different levels so that we can determine, okay, weakness starts here and goes all the way down, or else weakness is in just sporadic muscles. And it helps us determine, is there an injury going on, something pressure in the spinal cord, or is it just a peripheral nerve injury, and differentiate between that. Of course, the PT is the one doing that, but you need to kind of understand how they're assessing the patient and why and what their assessment means when you read the plan of care and the PT eval. Okay, how to determine motor level. So we do manual muscle testing. We test from caudal to, what do we say? Caudal, but up. Superiorly. And so we would start at the bottom, work our way up, and it's determined by the most caudal key muscles that have a muscle strength greater than 3, and then all the muscles above it being normal. Okay, so you're going up and you're getting 1 out of 5, 2 out of 5, 2 plus out of 5, 3 minus out of 5. Once you get to the level that has a 3, and if you start testing up and everything above that is, a good 4 out of 5, good strength, then that is your level. The level that tested 3 with everything above it being normal. Everything below it being 3 or below. If you have several segments in a row that are 3, then you could do like the lower of those. You won't be determining level ever, but that's kind of how they determine level. They do manual muscle testing, see what muscles are available, and once they get a grade of 3, they test above that, and if those muscles are normal, then that is their level. There's also a motor index score where you have 5 key muscles in each extremity, and you give them a score on a scale of 0 to 5. I think I have it written out. What 0 means? Do I? No, I don't. Anyways, 0 to 5, and you give each, on your manual muscle testing, 0 is nothing, 5 is full strength. My brain has left me this morning. And you give them a grade on each of those key muscles, and then you total up their score. So if they had a 5 out of 5 strength in their biceps flexors and their tricep extensors and, all of their key muscles throughout the arms and legs, then it would be 100 points, and that would mean they are normal. And if they had 2 out of 5 on all 5 of the key muscles in both arms, then the arm score would be 20, 10 here for one arm, 10 for the other, and then the leg score, if they had full strength, could be 50, based on what you've got in there. So that kind of can help you understand how they got the motor index score. They did manual muscle testing, give them muscle grades in the key muscle groups, and then gave them an overall score. Asia key sensory dermatomes. So these are, I'm dying today, I'm sorry. Areas of, so remember the dermatomes are areas that are fed, the sensation goes to that area of the spinal cord. So if you're talking about whatever area you're talking about, let's say you're inside your elbow and it's T1, then the sensation from that area of your arm goes to T1 area of your spinal cord before it travels up. That's all a dermatome is. So the key dermatomes are areas that you can check for sensation to determine kind of the level of injury. So T4 is at the level of the nipples, T10 is at the level of the belly button, L3 is at the level of the knees, L4 is the medial malleolus, and L5 is the lateral malleolus. No, S1, I'm sorry. I have to see further down. S1 is the lateral malleolus. S2 is, this is the back side over here. S2 is the back of the thighs or hamstrings, and then S3 is the ischial tuberosity. And we typically don't go that far as our assessment. Now, some people that are PTs that work in that setting would definitely check there. Otherwise, it's the medical doctor that's really checking and determining level. Typically, the PT is not assessing unless they're reassessing to determine, is some sensation returning, is some motor function returning. Otherwise, they typically will come to PT with already a diagnosed level. Okay, so here is how we determine their sensory level. So we use light touch. You can use pinprick, soft dull, and you rub or prick an area. And if they have no sensation, it's a 0. Abnormal is a 1, and normal is a 2. And then you determine which areas have normal sensation. I'm so sorry, guys. Okay, so these are the tracts in the spinal cord. Remember, I mentioned earlier the tracts that descend, they go down the spinal cord, lead to your motor function. So it comes from the brain, it goes down and out the spinal cord to tell your muscle to move. The tracts that ascend the spinal cord come in from the skin, they go into the spinal cord and up to the brain to tell the brain how things feel. Now, why this matters as far as where they're located, we're about to go through which portion of the spinal cord is injured and what types of effects that would cause. So knowing somewhat where things are in the spinal cord can help you understand why it affects that. So the back portion, the dorsal column, it primarily more sensory than motor, and it is fine touch, proprioception, and vibration that are transmitted in that area of the spinal cord. We'll stay on sensory for now. Pain and temperature are on the lateral portions of the spinal cord, and light touch is on the front or anterior portion. With motor function, the lateral and the anterior are the primary areas that there are tracts for motor function. Now, some of them travel ipsilaterally on the same side, and some of them cross over and travel up. So if the anterior cord is injured, it's often how it's injured is like a flexion, so like a severe flexion of the spine, and it could also be from an artery occluded from some type of trauma. But the symptoms would include decreased temperature, pain, and loss of motor function at and below that level. If it's complete, if it's incomplete, there could be some spots that it has some sensation and motor function. Now, proprioception, light touch, vibration are all intact, because that portion of the cord is not affected. So if the anterior cord is damaged, then they lose temperature, pain sensation, and motor function below that level. And then autonomic dysfunction, so kind of difficulty controlling heart rate, blood pressure, other things like that can be related and a common symptom with an anterior cord injury. Make sure I don't miss anything I had written below. So anterior cord, it just said, is primarily motor function. Okay, posterior cord. So with the posterior cord, it's a more rare site of injury. Reason being, that's the back, the very back portion, and you have all the bones of your vertebrae that are there kind of blocking some of that injury. And also, we typically have a lot more flexion motion than extension, so it's a little bit hard to hyperextend so much to damage it as easily. So it could be an occlusion of the posterior spinal artery. It could be trauma. It could be a degenerative disease like multiple sclerosis. And with the posterior spinal cord, the symptoms are loss of sensation, but no loss of motor function. Remember, motor function was in the side and front. Sensation primarily was in the back, some on the side, and other areas. But so primarily loss of sensation at and below that level, below that level, not at, below that level. And the thing with it is, even though you have motor function, it's really hard to coordinate movements in order to walk or do functional activities when you don't have sensation. So even though everything's intact and able to deliver motor signals to the areas, it is very difficult to actually move that area when the sensation is blocked. And one example of that is, for me, when I had my first child, I had an epidural. And so, of course, all it does is it blocks sensory input from that area. It does not block motor input. However, my legs felt paralyzed. I couldn't move them on their own at all. I couldn't activate my muscles to push. I couldn't feel anything down there, and I could not figure out how to move anything from my, hips down. And so I would have to take my hands and literally move my legs, even though I technically had motor function. They just wouldn't do what I was telling them to do. So that would be the same way. It's difficult to use what motor function they have. Stereognosis is the ability to recognize an object without looking at it. So just by touch, like if you're reaching in your purse trying to find some gum and then you're able to find it and pull it out, that is stereognosis. They would also lose that. The ability to recognize objects by sensation because they don't have that sensation. Also, the inability to recognize 2-point discrimination. I mean, I'm touching you here or here, but they cannot feel that. Pain and temperature are still somewhat intact, but the vibration, proprioception, those types of sensation are gone. Okay, with a central spinal cord injury, this is actually the most common type of cord injury. And it could happen with extension injuries. It could happen with compression injuries. With spondylosis, if something is pressing in and narrowing the spinal column and just constantly putting pressure on it, then eventually it could cause cord damage. And the symptoms include increased spasticity, increased reflexes. The arms are more involved than the legs, more motor loss than sensory loss. So I think that's a very interesting display of symptoms, that there is significant weakness and lack of sensation in the arms, and then some throughout the trunk, and then the legs don't display so much of the issues with motor or sensory. I think there was one other thing I want to tell you about that. Okay. Yes. So that's the central cord lesion. With Brown-Séquard syndrome, that is basically 1/2 of the spinal cord has been damaged. So it could be from it being cut, or somehow portion of it being removed, a hemisection. Could be a stab wound, something where it's just very precise and in the area, and that would cause Brown-Séquard syndrome. So the symptoms are loss of movement and proprioception on the same side as the lesion. So loss of motor function on the same side, because a lot of the motor pathways come down. When they cross from the brain, it's up at the level of like the medulla. It's not at the level of the spinal cord. And so they would cross up here and then travel down on the same side as the damaged spinal cord. But the sensory loss typically will come in and cross over within the spinal cord before it travels up to the opposite side. So that will be lost on the opposite side of the body. So if there was damage right here on the right side of the patient's body, their right-sided motor function would be gone and their left-sided sensation would be gone. The main sensation they lose is pain, temperature, light touch. But they also lose some sensation on the same side, like vibration, proprioception, deep pressure, all of that. So it's a very peculiar display of symptoms. And again, even if there's intact motor function on one side, it's very difficult to coordinate movements when your sensation is gone. Okay, it's just kind of an overview. So paraplegia, your arms are spared and the symptoms are in both legs. With tetraplegia, all four extremities are affected. If it was a complete lesion, no sensory or motor function below that level. If it's incomplete, there may be patches where there's sensation or motor function or both. With Brown-Séquard syndrome, you lose motor function on the same side as the injury and sensation on the opposite side. With central cord, primarily the arms are affected and you lose motor and sensation in the arms, but just sensation throughout the trunk and possibly the legs. With posterior cord syndrome, it's primarily loss of sensation below the level, and with anterior cord syndrome, sorry, I was trying to figure out, you're losing motor and sensation, most of your sensation below that level. So central cord is the most common, anterior cord is kind of the most significant. And then Cauda equina syndrome. So syndrome at the level of L2, rather than being like a bundle of nerves, they start to kind of fan out and become individual nerves that are just traveling through the spinal column. So at L1 and above, it's a bundle of nerves, the spinal cord, and then peripheral nerves enter and exit into that cord bundle. But once we pass L1, the cords start to become individual the nerves start to become individual nerves that are just traveling in a column together before they exit out. So if any area below L1 is damaged, then it's known as Cauda equina syndrome. And Cauda equina means the horse's tail. So of course, these nerves fan out like a horse's tail. The conus medullaris is at the sacral portion, S3 through 5, kind of the bottom area there. And any of that would be damaged would be still considered Cauda equina syndrome. It could be caused by spinal stenosis. Maybe they have a herniated disc that's pushing into the spinal cord, or that pars interarticularis. Remember, that's the broken pars articularis. So that would be, let's see, we're talking about, remember there's spondylosis, which is narrowing, spondylosis, spondylolisthesis, spinal stenosis. Spinal stenosis is narrowing. Spondylosis is that break in the bone, and then spondylolisthesis is where I'm getting to, is where the vertebral body has slid into the spinal column and it's pressing on the nerve. So that could be a cause of Cauda equina syndrome as well. It could even significant inflammation, a tumor developing in the area. Any of those things can push on the spinal cord at any point, but if it happens below L1, it would be Cauda equina syndrome. It's considered a peripheral nerve injury because it's not spinal cord itself. It's the nerves that have exited the spinal cord, but it is a medical emergency. If the pressure is not relieved and taken off the nerves, then the symptoms are irreversible. And the symptoms include saddle anesthesia, so numbness in all the areas that you don't want numbness, where a saddle would touch if you're riding the horse. Loss of sphincter control, so inability to stop defecation, but also inability to push out the matter as well, to open and push out and defecate. Then the legs lose motor and sensory function, so inability to use the legs, the leg muscles, and to feel what's going on in legs. Absent reflexes, and then this is the key, loss of bowel and bladder function. I say this is the key because this is typically the red flag that tells us the person has Cauda equina syndrome and what kind of gets them interested in going to a neurologist in the first place. So if a patient has a history of herniated disc and they say anything about a change in bowel and bladder function or even sexual dysfunction or anything like that, like erectile dysfunction, anything, then I would definitely have them return to their neurologist immediately and be checked out, or go to the hospital. If it's a sudden, it happened today, the neurologist doesn't know about it, go to the hospital and get it checked out, so that they can relieve the pressure, and then these symptoms can be reversible. But if the pressure lasts long enough, it will damage the areas and it will be irreversible. Okay, some of the definitions. So quadriplegia is also known as tetraplegia. We kind of mentioned it earlier, but that is loss of movement and sensation in all four limbs. Typically, it needs to be at a level between C1 and T1 in order to affect all four limbs. Once it's below T1, then it's primarily trunk and lower. Of course, once it's above C6, that you start to get damage to some of your autonomic functions, like breathing and heart rate and stuff. So sometimes it could cause death, C3, especially C3 and above. But quadriplegia is typically above T1. And then quadriparetic, it could be in the same area, but instead of complete paralysis, it's weakness. So there is some movement below the area. So it's weakness, all four extremities are affected, but it's not full-blown paralysis. Versus with paraplegia, that is just the lower extremities that are affected. Now, some of the trunk can be affected. And paraplegic would be paralysis, complete paralysis. It would be basically from level T2 or lower. And paraparetic is just the weakness, still level T2 or lower, but not complete paralysis. And of course, you all know by now hemiplegia is loss of sensation, motor control on one side of the body, and typically it's from a brain injury like a stroke on the opposite side. A syrinx or a cavity is a hole left by the injury that it's the whole area is cell death. There's been cell death in the area and it's a hole left. Typically when the hole fills with cerebral spinal fluid, it's known as a syrinx, and it occurs within days of the injury. Then the area around that, there's a fibrotic scar and then there's a glial scar. So a glial scar surrounds that cavity, and it's continued cell death. So it didn't happen from the initial injury, but from the things we learned earlier about the inflammation and the lack of good nutrients coming to the area, and the buildup of toxins in the area, then the mismatch of the chemicals that are needed to really allow energy transport in and out of the cells. All of that creates a really horrible environment that causes cell death, and that is the glial scar. So it's not the original area that was injured, it's the area that's been damaged since. And that can occur and continue to progress weeks to months after the injury. So if somebody, immediately after a spinal cord injury has movement of their toes or movement of different things and then starts to get worse, it may be because of the continued cell death and damage from that secondary spinal cord injury and the glial scar. Spinal shock. Now, this is kind of the opposite of what we were just talking about. So spinal shock is immediately after a spinal cord injury. There's sensory and motor loss that appear worse than they are. So immediately after the injury, the body goes into this shock state where it kind of shuts everything down below the level of injury, and it looks like it's a complete injury. Typically within a few days, sometimes it will take several weeks for the shock to kind of reverse, and the end of spinal shock is signaled by a muscle spasticity, a reflexive bladder emptying, and then increased reflexes, hyperreflexia. And that's when you know the patient is coming out of shock, and that's kind of when you can get a true diagnosis of their level of injury. It could appear worse initially and then appear like it's improving, but it's just that the spinal shock has resolved. But neurogenic shock does not typically resolve without medication. So typically medication, something needs to be given to help it resolve. This is that there is a buildup of products at the level that cause loss of sympathetic nervous system function. It can create an autonomic instability, so it can create, it changes your vital signs. So basically, the blood pressure will drop because of the decrease in circulation. It can cause nausea, vomiting, it could cause fainting, sweating. It could decrease your heart rate enough that it could be fatal if medication is not administered to kind of reverse this process. So they go into shock, the blood pressure drops, the heart rate drops, and then once vasopressors are given, it starts to elevate the heart rate and kind of return everything to baseline and be able to deliver the cells what they need, oxygen primarily and other nutrients, and return to more of a normal state. Autonomic dysreflexia. So with spinal cord injuries that are at or below or above T6, they can affect your autonomic nervous system. And so remember that's your heart rate, your blood pressure, respiratory rate, all of those vital functions. And so typically with somebody who has a spinal cord injury at T6 or above, if there's any noxious, like painful stimuli below that level, although you can't feel it to know and to remove it, their brain still receives some sort of input and signal because of the lower levels of oxygen in the area. So like, let's say there's something compressing. It would be in the leg somewhere or in the trunk or whatnot, compressing. Well, if there's a compression happening, less oxygen's getting delivered. Your brain will pick up on the fact that that body part is getting less oxygen, even though it's not feeling the pain, for you to look at the arm and see what's wrong and fix it. And it will still respond to that. And so what it often happens with bowel or bladder irritation, like maybe they need to use the bathroom really bad, they haven't done their catheterization in a while, and it's so full that it causes them to begin to have the symptoms. And or it could be that they're constipated and haven't had a bowel movement in a while, and it causes those symptoms. If you think back about some time that you had to like poop really, really bad and think of some of the symptoms you had, it will remind you of autonomic dysreflexia. So here are the symptoms. Temperature rising, so could be a temperature of 101 or above. Your blood pressure goes up, your heart rate goes up, your respiratory rate goes up, you start sweating, getting agitated, maybe even shaking a little bit. and dystonia or increased spasticity. So maybe shaking, maybe drawing up. And all of that is in response to some type of painful stimulus below the area. Now, as far as from kind of a what is exactly happening standpoint, so there's a stimulation below the level of injury, and a response is delivered to the brain to say, hey, something's wrong here. And that actually causes a massive sympathetic nervous system response. So the blood vessels throughout the body constrict, which causes hypertension because the blood vessels are so restricted that it's harder for the blood to go through, so it has to increase to go through the vessels. Then that high blood pressure, the input is received by the vasoreceptors, and tell your brain that there's kind of a crisis going on, and that causes your heart rate eventually to slow down. But initially, it's sped up and all that. Now, what do we do for autonomic dysreflexia is the main thing. We want to look and see what's going on. Oftentimes it's because their pants are too tight. I would definitely start at clothing. If the clothing is binding or restricting, if it's too tight, then remove those or change the clothes, whatever you need to do to get it less restrictive. Check the catheter, make sure it's not blocked, empty whatever portion's still in the line to make sure that it's freely flowing out. Ask the patient, have you had a bowel movement recently? When was the last one? Was it normal? Just determine if they're constipated. Check their position. They may need to just change position. It might be that there's some skin breakdown going on because they've been in that position too long. Remove that trigger, and then if the symptoms don't subside, they need medical treatment immediately. It can be life-threatening if it is allowed to go on too long because all of their vitals are out of whack. And the thing about it is it typically occurs at least 3 to 6 months after a spinal injury. So that's when it might begin happening. It could be a year later. It could be a while later after an injury that something is painful or is irritating below the level, and then their vitals go out of whack. So you really need to educate patients before they're discharged from like a rehab facility or a hospital setting to know what to look for, what the signs are and what it means, and how to check, is there anything I need to do to relieve the pressure or the pain where the ailment is, so that I can return my vitals to normal. So education is huge because they may be home at this point and may not, know what to do. Okay, so with spinal cord injuries, there's some common functional limitations. Of course, most have difficulty walking or are non-ambulatory, and decreased independence with mobility, including transfers, bed mobility. May not react to painful stimuli, which would increase their risk of getting pressure sores and infection. Decrease independence with their ADLs, may lose bowel and bladder function, may experience sexual dysfunction, and may have difficulty with their vitals like breathing, swallowing, life-sustaining activities. And all that depends on the level of spinal cord injury. Some of the complications and how they affect treatment. UTI is actually one of the most common causes for people with spinal cord injury to be rehospitalized. So educating patient on proper hygiene and on importance of emptying the bladder frequently and fully. How to use a Foley catheter. Of course, that could fall on the nursing staff and other staff rather than us, but just the signs of a UTI, all that we can still educate the patient on. Contractures, we can do passive range of motion and stretching, give them home exercise program, caregiver training to avoid contractures. Pressure ulcers, we already know. Position changes are key every 2 hours if they're laying, every 15 minutes if they're sitting. And make sure you assess the area for skin breakdown, teach them to assess their area, and educate them on the importance of being clean and dry. If they have a diaper on or something, or if they've soiled themselves, they need to get that taken care of quickly because the skin breakdown will happen at a much faster rate if they do not. Respiratory complications, we can do chest PT, but of course standing and sitting up in bed can really help decrease those complications as well. We can teach diaphragmatic breathing. That's kind of a key after a spinal cord injury because sometimes the diaphragm is affected, sometimes the muscles of respiration are affected, but if there's some strength in the diaphragm, that can be a key one to teach. Edema, we can do passive range of motion. We could do edema massage, but make sure you're not doing edema massage over an area that could possibly have a DVT, deep vein thrombosis, that blood clot there. Remember how the signs of DVT: redness, heat, pain in the area. If it's in the calf, you can squeeze the area one time, and if that increases their pain, that's the Homans test, then that is a positive Homans, and they may they need to be checked for DVT, and you don't want to massage that area for sure. Compression garments and those compression devices can all help decrease the chance of DVT by increasing the blood flow and not allowing it to pool. And then depression, monitor the mood, refer to a psychiatrist if needed, educate the family members on signs of depression, anything like that. Refer out if you do feel the patient is depressed. Some other considerations. So a spinal cord injury at a level of T6 can affect the respirations and the autonomic nervous system. And even though their sensation is decreased, many have neuropathic spinal pain. So it's like a burning sensation below the level of injury because their neurons are just spastically firing. So they're not getting good receptive feedback from the neurons, but the neurons are kind of like, what's going on, and just firing at random, and their brain is interpreting all that as pain, especially burning, a deep burning sensation. So just understand that if the patient's constantly saying they're in pain, don't say, well, you don't have sensation, you can't be in pain. They absolutely can. Even phantom limb syndrome, even if their leg is gone, they could have pain in a leg that's missing because their neurons are firing and their brain is interpreting it as pain in an area that's not even there. So they absolutely can have pain. Precautions for patients with spinal cord injury: they need to make sure they are taking care of their skin. With their sensation being decreased, they're at a higher risk of pressure ulcers developing. Prevent contractures with their immobility. They need to make sure that they're continuing to do passive range of motion in order to decrease their risk of contractures. With the bladder care, they can use catheters. You want to educate them about not overfilling the bladder or doing it too infrequently and the risk of UTI. With respiratory care, they may have decreased control of the diaphragm or the respiratory muscles. So sitting up, that's going to put them at a higher risk of pneumonia. Sitting up in bed, standing up if possible, chest PT, deep breathing if possible can help prevent that. And then edema, being immobile. Remember, your muscle pumps are what are responsible for sending the blood back to the heart. And if your muscle pumps are not working, and a lot of your muscle pumps are in the legs, then the blood will just pool in the area and not be returned to the heart, which can cause edema and also kind of change the blood volume available for use throughout the body. Orthostatic hypotension, you guys know about this by now, but it's a sudden drop in blood pressure with a position change. Typically, it's either from supine to sitting or sitting to standing. Symptoms include dizziness, sweating, fainting, maybe some floaters in the visual field, and sudden paleness. Now, one thing I have at the bottom is if the patient is red, raise the head. So if you've noticed they're really red, raise the head of the bed. If the patient is pale, raise the tail is what the saying is, but really you lower the head so that they're more flat and more blood is getting to the brain. So if the patient is suddenly red and, really hot or whatnot, you can raise the head to decrease the blood that's rushing to the brain. And if the patient is pale, raise the tail. So lower the head so that they're getting more blood to the brain. Some of the treatment considerations when working with somebody who has orthostatic hypotension, slowly change positions. Let them sit in each position for a while before you go to the next position to allow them to recover a little bit. Make sure, ask them how you're feeling. If they need to sit back down once you stand, and have something close by so that they can. Throughout their stay, if you can have them change positions frequently, go from supine to sitting in various positions while they're in bed, like as part of their home exercise program, that can help them get more used to an upright position and tolerate it better. And then always monitor their blood pressure while you're changing positions to prevent complications and to pay close attention to avoid them passing out and to get them in the right position to protect them for their safety. Benefits of standing. So we've talked about this before, but it's really important. Even if a patient is paralyzed in their legs and may never be able to functionally stand and use that to do functional tasks, having them in a standing position when possible, either through a tilt table or a stander, can still provide them a lot of benefits. It will decrease their secondary complications. It can decrease their likelihood of getting orthostatic hypotension, decrease their spasticity. It can fight against osteopenia because it helps them reabsorb the calcium that's being lost from their bones. It can increase their intestinal mobility, so decreasing their constipation, and it can help normalize their sleep patterns. So it's still huge. They can get a lot of benefits from standing, even if it's not functional. Gait training also has benefits if you put them in some device that can support their legs and allow them to gait train even with significant weakness or paralysis. Some of the physical is it helps them maintain range of motion, increase strength and endurance, decrease spasticity, improve bowel and bladder function, improve circulation. Some of the functional is it could help with pressure relief, it could help with ADLs, or access to certain areas like it's doing a stand transfer in and out of the car, or places where their wheelchair doesn't fit very easily. It can increase mobility within the household or around, even if you can get them to a place where they're able to take 2 or 3 steps, that can really open up a lot of opportunities for different types of transfers and more independence. And then psychological interactions at eye level really increase the mood and increase confidence and acceptance and their own acceptance of their disability. It can decrease their depression score. So if there's a possibility of getting them to, to be able to stand and take a few steps, absolutely do it. Even if they're just in a stepper or something that's taking the steps for them, it can really benefit the patient. And I believe this is our last slide. So bowel and bladder management. When the patient's not able to defecate, they can rely on what's called a reflexive bowel movement. So the external anal sphincter is either stretched or stimulated, like a rotational stimulation, and it causes them to reflexively have a bowel movement. Typically, they're taught how to do it and to do it at the same time every day in order to stimulate, and get their bowels on a regular cycle. We don't teach that, but we definitely can talk to them about that. How is that going? Is that working for you? Are you having regular bowel movements? So that we know kind of their status. They're typically taught to, if they're able after a spinal cord injury, they're typically taught to self-catheterize. If they're not, maybe a caregiver may be educated on that. Could use an intermittent catheter. It goes in to empty and then it comes right back out. Could use an indwelling catheter that stays in, but that if so, you're more likely to get urinary tract infection. So educating on that and on the importance of emptying the bladder frequently. Remember, your urine has a lot of things in it that your body's trying to eliminate. And so the longer it sits in your bladder, the more likely you are to get an infection. You want to get that out as often as possible. And then full bladder can lead to urinary tract infection. It could lead to hydronephrosis. So that's the kidney swelling because of, urine backup. It could lead to renal calculi, that's like kidney stones, calcium deposits. Could lead to bladder calculi, so stones within the bladder. And then vesicourethral reflux. I practiced it earlier, but it didn't work, did it? Backflow of the urine up into the ureters, and that would cause an even worse infection. So that is our lecture on spinal cord injury. And please let me know if you have any questions. And I look forward to seeing you guys in lab to practice some of the treatment techniques.